Okay. Dr. Mattox is up next for Symbiosis and Serendipity in Surgical Process, and he's instructed me to make sure he stays on time, so we'll see. So I have his permission.
Thank you very much. Let me start by saying this is a talk about aortic trauma as a surrogate for big bad trauma. There are individuals in this room and hospitals represented in this room meaning the global cyber room of this international meeting. There are those individuals who have never, ever had a survivor of penetrating wounds of the aorta. It is a big challenge, and as such, there are changes that occur over time, and this talk is about symbiosis and serendipity in aortic trauma management. Symbiosis is two or more organisms or systems that coexist to the benefit or the detriment of the other. Together, interacting, dependent, detrimental, coexistent. Serendipity is the fortunate happenstance and often surprise happenstance that influences and impacts another activity, usually for the better, sometime for the worse. Such things as surprise discovery, chance observation, an innovation, an accidental benefit. And each of you have had such epiphanies during your lifetime. Aortic etiology, injury etiologies are well known to you. Some of those are iatrogenic, and those iatrogenic ones are increasing, especially with the non-surgical interference with REBOA by some of our colleagues in the world. What happens after an aortic injury is well known to you. Rapid blood loss, hypotension, tamponade, cardiac cessation, and very often death. In aortic injury, there's no ancient history. All of the history for aortic trauma is in the last 100 years, most of it in the last 50 years. And advances are limited to the last 50 years or maybe impeded in the last 20 years. Why? All patients died, no systems of care, no trauma centers, blood banks, and the like. There was no history. There was early lack of anesthesia, endotracheal intubation, no suture, no instruments, no prosthesis, no antibiotics. And so that with that history, there was then a symbiosis which allowed aortic trauma to be approached. Various historic happenstance likewise influenced, especially inquisitive young surgeons. Part of the message of this talk. That's serendipity. Aortic trauma anatomy occurs all through the aorta. I don't need to repeat that. The beginnings occurred about 130 years ago with the first epiphany, when an intern by the name of Alexis Carrel observed an autopsy with a single injury, a stab wound to the portal vein. During that observation, Alexis Carrel said, there has to be a better way, serendipity. That same individual with that better way developed triangulation, and with that triangulation won the Nobel Prize 7 years later at age 38. Serendipity. Fortune favors a prepared mind. The first aortic repair was done 1 year after that Nobel Prize on October 27, 1913, when Danletz sutured an ascending aorta with 3 sutures. He was age 30, he had had previous heart injury repairs, he had a 20-year-old with a stab wound to the left of the sternum. 2 hours after arrival became unstable, and he ligated the internal mammary, released a small tamponade, and had an 8mm ascending aortic injury laceration. He repaired it. That was 102 years or so ago, serendipity. Opportunity. That occurred with favorable and potential unfavorable incidences could have influenced that repair. There is always a better way to do things. Society also, events in society can impact surgery. It's in the case of the elephant. The elephant happens, like the rhinoceros, to have an ivory tusk. At that time, years ago, billiard balls were made from ivory, and there was a shortage of ivory. A prize of $10,000 was offered for an alternative product. With petroleum engineering, bakelite was discovered in 1955. Plastics were born. And with that development of plastics, bakelite, an entire industry that occurred with the development of all sorts of things. A series of world wars occurred, and there were various advances during those wars. I will not talk about those wars in this talk. But out of those wars came a young Dr. DeBakey, who was early instructed to infuse blood from one patient to the other, and because he wanted to make it easier, developed the crimping on the tubing of a device where he transferred blood from one patient to the other. This was an opportunity, but blood banks killed his invention. It had to go to the basement. Serendipity. Serendipity progress sometimes puts old devices into storage. Dr. DeBakey came to Houston. I'll not go into those details, but he at that time wanted to do surgery on the aorta. He was able to scavenge homographs from the charity hospital. No IRB, no permission, no screening, and these homographs were then put into the abdominal aorta and to the thoracic aorta, and all of them developed false aneurysms within a year. Frustration, needing a new fabric. Serendipity, he could no longer use those homographs. So he went to the Sears store, which is still open, and said, "Sell me some Orlon or nylon." The sales lady said, "We're fresh out of those, but we do have a new substance called Dacron." He said, "I'll take it." He then had an aha moment, sewed that Dacron, and serendipitously created an entire new industry, which affects us even to this day. Look for that adaptive opportunity. Between 1955 and 1965, a number of things occurred. Parmley reviewed his aortic papers that said there's an opportune time for repair. NASA was developed, cardiac surgery developed, need for war machines, need for new metals. And out of that came a need for better rocket cones. Those nose cones were looked at by, they needed to be resistant to fatigue, heat, and impact. The Naval Ordnance Laboratory in 1959 had a nickel titanium alloy which was folded like an accordion, and then it was passed around the room. One person put his cigarette lighter to it, and boop, it reverted to its previous shape. Bingo! Serendipity, a new product called Nickel Titanium Naval Ordnance Laboratory. Nitinol was developed. That became a biliary stent, a bronchial stent, which later was used off-label to be a whole new industry in vascular prostheses. Symbiosis. That new industry we could spend the next 30 minutes on, we will not, but that symbiosis proceeded. Francis Usher took advantage of some of these movements. He was a hernia surgeon and did not have anything but suture and biologic material to use. He went to Phillips Petroleum developed a whole new industry with initially polyethylene, then polypropylene, and this industry of mesh, which now is a multi-billion-dollar industry, was born. New suture came out of that. Continually improved products to match the needs, symbiosis. Vascular surgery at that time was silk. Wax applied to smooth the outside of the silk. That had early fatigue, created pseudoaneurysms, and so out of frustration, Dr. DeBakey went to Francis Usher and said, make us something different. Francis Usher said, use non-braided polyethylene initially, and then they went to polypropylene. Bingo, symbiosis occurred. 1960, a young resident, Arthur Bell, who has made significant contributions in device regulation and cardiovascular techniques, discovered that there had only been 14 previously successful cases of aortic injury worldwide through 1959. And he reviewed that material, had some cases of his own, and found that there was a significant mortality and said there's got to be a better way. It was almost universally fatal at the time. I've already told you some level 1 trauma centers, even till today, have never had an abdominal aortic injury survival. But at that time, Lee Harvey Oswald, the alleged assassin of President Kennedy, himself was shot. 50 years after the first aortic repair, I was a junior at Baylor. I watched that event. I then learned that the injury is only abdominal aorta, superior mesenteric artery, and IVC. 3 tubes, 3 simple tubes that we repaired every day in Houston. As a naive junior medical student, I said, someday I'm going to get to be able to approach that injury, and it's just sewing up tubes like we do every day. It cannot be that difficult. Serendipity. So I thought about that a long time, and we'll get back to that. Norm Rich at the time developed a registry and talked about the various wars and used that registry for innovation with that data registry. 64 through 67, just a few years ago, trauma centers were developed, and with those we had the combination of fast transport, patients that could be approached with new kinds of technology, ICU care, and symbiosis. We verified trauma centers, immediate operating room, loop closure, outreach, and education. But then along came Robert Gore and Ben Eisman in 1970 in the mountains of Colorado. It's all a state of mind if you're in Colorado or many states in the West. So in 1970, both of these individuals left to climb mountains. Bob Gore, an industrial engineer, had created a product, expanded polytetrafluoroethylene, that he called Gore-Tex, but he didn't know what to do with it. They were climbing mountains one day and had, after this expenditure of a lot of money, and he didn't have anything else to do, he said, I'll just make a tie out of this white material, and he did. At dinner, with Ben Eisman after climbing mountains, he said, let me show you this. It holds water. I can squirt mustard on it, and it doesn't turn yellow, but I don't know what to do with it. Ben looked at it, blew through it, poured water on it, said, can you make that into a tube? And he did. So he had a tube of Gore-Tex, but Ben Eisman only replaced a portal vein with a cancer of the pancreas with it, never ever used it in any sort of trauma. But that entire industry resulted in a serendipitous new graft that we all use every day. That same year, serendipitously, I encountered a 3rd time penetrating wound to the abdomen with an injury to both kidneys, the IVC, the abdominal aorta, and I was only a fifth-year resident. No faculty would ever come in. And I had to then approach this, which we did, by a retroperitoneal approach. Here is that operative report with a drawing I made at the time. There's always room for a new approach. Stan Crawford, at about the same time, felt that patients with ruptured aneurysms must be kept hypotensive. Do not give crystalloid. He kept data on his complications, and that resulted in ultimately three major shock trauma studies in Houston, Texas. The next decade resulted in significant changes in new technology, CT scanners with Symbiosis, teaching hospitals and aortic injury. Young surgeons, many of whom had had time in Vietnam, made tremendous innovations, all in the 30 to 36 year time frame. Symbiosis to make things happen. At that time, the reports of aortic injury, vena cava injury, iliac artery injuries, portal vein injuries were reported. The best results that had ever been achieved in the world. All improvements from the past. Times began to change, and from '84 onward, a number of studies moved forward. I'll not go through all of those in the interest of time, but just like Crawford, we withheld crystalloids, we treated with hypotension, and a number of advances were made in aortic trauma, including those in the thoracic aorta. Dr. DeBakey was able to pull out of the basement the pump that he had developed for transfusions because John Gibbon had an oxygenator but not a pump. They put them together, Serendipity and Symbiosis. A number of things begin to diverge. Thoracic, vascular, and trauma surgery diverged during the 1990s. New turfs developed, and vascular trauma became its own independent specialty. Serendipity crises. Endovascular advances occurred. New balloon technology was developing, Carl Hughes starting in 1950. Use of intra-aortic balloon pump to include even traumatic injuries occurred during those early years. And percluder technology was developed at Baylor as shown here, almost identical to the Reboa of today. It was discussed in the 1975 paper in the Journal of Trauma, and you can read it there today. That was 40 years ago. This group of individuals use this device, but after several months, abandon. Why? Aortic endotherapy continued, and both vascular surgeons, thoracic surgeons, interventional radiologists pursued that technology, and Reboa emerged. Reboa is a new technology that we'll talk about more this afternoon. Intra-aortic ultrasound has emerged that even in some hospitals has replaced arteriography and CT scan, with patients going directly to the operating room for their endovascular therapy. So with all of this explosion in aortic approaches, serendipity and symbiosis works together. But there are surprises. There are a number of things that did not happen. Dr. Feliciano talked about the advances of thoracic treatment yesterday. The historic progress was interrupted, and as I enter the end of this talk, I want to share with you that with all the advances and the diversions we've made since 1980 up through 2015, we can and should do better. And so the results today that are discoverable are no different, and in many instances worse than they were in 1980. There are a number of reasons for these changes. Some of them are policy changes. Some of them are serendipity. Some of them are symbiosis. Some of them are from the vascular surgeons. That tells me it's time for me to shut up. But I will leave you with both the military surgeons. There's only 15 vascular surgeons in all of DOD. Both the vascular surgeons who like wires and endografts are scared to death of an open abdomen. They do not have the technology to approach iliac and aortic injuries. We are facing a problem, a big problem. So the question is, who is making the future history in the treatment of the big, bad injury? It's beyond the scope of this lecture to talk about such philosophy, but I'll leave you with a summary. The future transformational innovative surgeons are in this greater room, this cyber room, to make those changes of the future. Most of those who make innovation will take advantage of the symbiosis and the serendipity that is there, and most are between the ages of 30 and 36 years old. So the future of surgery is to recognize the new symbiosis, take advantage of the serendipity, and have the courage to fail. Thank you for letting me share this history with you.
Thank you, Dr. Mattox. Fantastic, fantastic talk. Any questions from the audience or comments? Those people online, again, I would encourage you please to, in the top right-hand corner, hit that question button if there are any questions, and we can read them.